Hi, in today's video, we will learn how to differentiate between the different types of brain bleeds using imaging findings and clinical clues such as lucid intervals and bleed shapes. We'll also dive into the pathophysiology of electrolyte imbalances in heart failure. So let's get started. A 28-year-old man was struck in the head by a falling heavy object while working at a construction site. He briefly lost consciousness but quickly regained full awareness and initially appeared well. Several hours later, while being observed in the hospital, he begins complaining of a severe headache and has difficulty moving his left arm and leg. Shortly afterward, he becomes drowsy and eventually unresponsive. A non-contrast CT scan of the head reveals a hyperdense, lens-shaped lesion and a fracture in the region of the temporal bone. Which of the following vessels is most likely injured? Now, when approaching questions involving head trauma and neurological decline, you should keep these three key concepts in mind. Number one, analyze the timeline of symptoms by paying attention to patterns like initial recovery followed by deterioration, which can indicate specific types of brain bleeds. Number two, interpret the imaging findings because different types of intracranial hemorrhages have characteristic shapes and locations on the CT scans. And number three, connect the anatomy with the clinical signs by understanding how trauma to specific skull regions relates to underlying vessels and potential bleeds. The options which are given in this question are A, bridging veins, B, anterior communicating artery, C, middle cerebral artery, D, middle meningeal artery, E, internal carotid artery. The correct option here would be D because this patient experienced the lucid interval after traumatic head injury in which the patient is initially relatively asymptomatic and then begins to rapidly deteriorate several hours later. This is highly suggestive of an epidural hemorrhage, which is further confirmed by the finding of a lens-shaped intracranial bleed on the CT scan. Epidural hemorrhages most often result from trauma to the temporal bone, which then lacerates the middle meningeal artery. The image provided here is an example of how epidural hemorrhage would look on a CT scan. Let's have a look at why the other options are incorrect. Option A is incorrect because tearing of the bridging veins can occur following trauma, but this typically results in a slow bleed during which focal neurological deficits develop over the course of days to weeks and not hours. This would cause a crescent-shaped bleed seen on imaging and not a biconvex lens-shaped bleed. Bridging veins are affected in subdural hematoma. And option B is incorrect because a hemorrhage of the anterior communicating artery, which can occur with berry aneurysm rupture, would result in a subarachnoid hemorrhage, which is typically associated with the sudden onset of severe headache and is unlikely to result from trauma given its deep location within the cranium. And option C is incorrect because the middle cerebral artery stems from the circle of Willis and perfuses much of the lateral aspect of the cerebrum. Trauma is unlikely to damage the middle cerebral artery. Furthermore, a hemorrhage from branches of this vessel could produce an intraparenchymal stroke. And option E is incorrect because the internal carotid artery feeds directly into the circle of Willis, where it splits into the anterior and middle cerebral arteries. A hemorrhage from this artery is unlikely to occur following trauma, as its course is deep within the cranium. Furthermore, a bleed from this vessel would not cause an epidural hemorrhage. A 70-year-old woman is brought to the clinic by her daughter due to increasing fatigue, swelling in her legs, and shortness of breath that worsens when lying flat. She has a past medical history of hypertension and a prior myocardial infarction. On physical examination, she has bilateral pitting edema of the lower limbs and elevated jugular venous pressure. Laboratory studies reveal a serum sodium concentration of 129 milliequivalents per liter. An echocardiogram shows a reduced left ventricular ejection fraction and signs of volume overload. Compared to normal, which of the following findings is most likely in this patient? From this clinical scenario, it is highly suggestive that this patient is likely to have a congestive heart failure, supported by the symptoms of fatigue, leg swelling, and shortness of breath. Her history of hypertension and prior myocardial infarction increases her risk, and the physical signs like bilateral pitting edema, elevated jugular venous pressure, and low serum sodium, along with the echocardiogram showing reduced left ventricular ejection fraction, confirm the diagnosis of congestive heart failure. In order to answer this question, we should understand the pathophysiology of congestive heart failure, particularly how it leads to fluid retention and electrolyte imbalances. The options provided here are A. Serum osmolality is decreased, B. Total body water is decreased, C. Serum chloride is increased, D. Cardiac output is increased, and E. Plasma vasopressin is decreased. The correct option here would be A. Serum osmolality is decreased, and that is because the cardiac output is decreased in congestive heart failure as the impaired heart function reduces effective blood flow to tissues, and the body compensates by releasing antidiuretic hormone to preserve the circulating volume. The antidiuretic hormone promotes water retention via the collecting ducts in the kidneys, and the retained water dilutes sodium concentration and lowers osmolality. Let's have a look at why the other options are incorrect. Option B is incorrect because total body water is increased and not decreased in congestive heart failure due to the compensatory mechanism of antidiuretic hormone release. And option C is incorrect because serum chloride is also decreased due to the dilutional effect of excess water in the extracellular fluid compartment. And option D is incorrect because cardiac output is decreased and not increased in congestive heart failure, as the heart has decreased pump function in systolic heart failure and a decreased relaxation in diastolic heart failure. And option E is incorrect because vasopressin is another name for antidiuretic hormone, and its secretion is increased as a compensatory mechanism in an effort to maintain perfusion of organs in congestive heart failure.